Good morning and good afternoon, everyone. I, on behalf of Association of Nurse Executives India, being the zonal head East, this is my proud privilege. I am also the founding member of ANI, who takes this opportunity to wish everyone and thank everyone for joining us, and also to let you know that today we are going to have our Empower Hour. But before starting the topic, it is a ritual for all of us to know that such a hard work of the anthem that has been created by Annie. Let us play the anthem. Dolly, over to you.
Thank you. We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do. Thank you. Over to you, Madhukaridi. Thank you very much.
Thank you, Dolly. So it's a proud moment for all of us.
Your natural healing system and manage lifestyle diseases just through natural methods and that.
Of course. See, there are three things that you need to understand if you want to live a disease.
I would request everyone to kindly put your microphone off.
Carry on.
this is my proud privilege to tell all of you that we are going to have our ANICON 2026 on 29th and 30th May 2026 in Taj Lands End, Mumbai, Maharashtra. And I would request everyone to take a note because this is going to be a ice-breaking event for both the days. As we do something, we always be innovative in our flagship events. And this is again 6th annual flagship event that we are going to have from Annie. With that, I take a note to start with today's Empower Hour. This Empower Hour actually every month we have from Annie, which talks about not only the patient safety. Of course, it focuses only on patient safety, and that is the reason we come forward to let everyone know and enrich knowledge by all experts to understand the disease processes, to understand how the patient can be safe in our hands, and we can make the entire disease process better and better outcome for our patients. So with that, it is very important for us that this Empower Hour is made so successful in understanding that how in every disease process or in every step, we play a major role to ensure that patients are safe when patients are in front of us and we are able to give our best to our patients. And with that note, today's Empower Hour is going to be, the theme is, I'm just sharing the theme. The theme is Nipah virus, a zoonotic threat. What should we do to combat in future? Which is, we all know that we had lot of incidences, few incidences in West Bengal, and that is the reason we felt that this is a prime importance topic for us, important topic for us to know about how, if in case we get cases, how we want to actually treat them, and we want to ensure we are safe and our patients are safe. So with that, I will start with a case presentation, which is going to be given. It is an A positive case of Nipah virus and with its consequences, which is going to be explained by none other than we have with us our first speaker who has handled this case in her hospital. We are having nursing superintendent Miss Mukta Chaudhuri. She is from NH Barasat, Kolkata, and it is very important for us to mention that we let us know how they have handled this case so differently and in a way that it has to be done based on the guidelines that we received from the West Bengal government. So let us see. Over to Mukta. Please narrate how the case presentation. Over to you, Mukta. Thank you.
Thank you, ma'am. Ma'am, my screen is visible?
It's visible. It is visible.
Okay. First of all, good morning, everyone. I am Mukta Chaudhuri from AYNA Multi-Speciality Hospital, Barashat. Respected seniors, respected dignitaries, and my dear colleagues, it is my honor and privilege to present a case on Nipah virus infection in healthcare workers 2026. Thanks to ANICON for giving me this opportunity to present on before you. Slides are not.
Just double click it.
Yeah. So first I will go to the few background of the Nipah virus. Human Nipah virus infection is an emerging zoonotic disease which causes severe illness in both humans and animals. First identified in 1998 in Malaysia, caused an outbreak of respiratory and neurological disease in pigs and encephalitis in peoples. Natural host is foodbred Pteropodus virus, and it is a paramyxovirus. Its incubation period is 4 to 21 days, transmitted through the contaminated fruits, dead palm sap, animal contact, and human transmission. Case fatality rate is high, 40 to 75%. First, it is recognized in 1998 during the outbreak among the pig farmers in Kampui, Sangay, Nipah, Malaysia. No new outbreaks since then in Malaysia. In 2001, Nipah virus infection outbreaks were detected in India, Bangladesh, Outbreaks have been reported almost every year since then. In 2014, an outbreak was reported in Philippines with no new cases since then. Recently, outbreaks have been reported from Kerala 2018, 2019, and 2021. In India, outbreaks are periodically reported in several parts of country. Shiliguri, neighboring Bangladesh, include the latest one in 2026 at Parashat, West Bengal. Here you can see the mortality and morbidity due to Nipah virus infection country-wise and year-wise. The mortality rate is high. So how it is transmitted? Fruit bats with the NIV feeds on the dead palm sap, and that sap is consumed by the humans. And sometimes fruit bat, they eat the fruits and the fruits are fallen on the grounds. Pigs, they feed the fruits. So this is the way how it is getting transmitted from the bat to pigs, pigs to human, and human to human. Pathogenesis, Nipah virus can be seen in epithelial cell of the bronchioles in the initial stage, and then Nipah antigen can be detected in the bronchi and alveoli. Inflammatory mediators are activated as a result of infection to the airway. Virus is spread to the endothelial cells of the lungs in the later stage of the disease. Virus enters into the bloodstream, followed by spreading either freely or through some media, and by bounding the leukocyte form, reach to the brain, spleen, and the kidneys. There are two pathways how it is transmitted to the central nervous system. One is hematogenous route, another one is olfactory nerve pathway. The blood-brain barrier is disrupted, and leukotriene 1 beta along with the tumor marker alpha are expressed due to the infection of the CNS by this virus. So this is the pictorial form of pathophysiology. First is embedded in the epithelial cell of the bronchial, then it goes into the bronchi and alveoli. Main target is to infect the epithelium of the bronchi, then third it infect the full airway of the epithelium, then it goes into the endothelium of the lungs. They form the leukocyte bound, and through the leukocyte bound it affects the kidney, spleen, GI tract, and also to the brain. Now I will go into the case details. Actually, there are two case details. Ma'am, this is visible properly?
It is visible.
I am, yeah. So first case, 25 years female, staff nurse from HDU. She's from Purbo Mednipur, West Bengal. Her date of admission, 6th January. Second case, 25 years male, staff nurse from MICU. He's from Midnapur. Date of admission, 4th. On admission, his temperature was 100.3 BP, 100/60, oxygen saturation 100% with FiO2 60%. GCS was 2/15, long latency reflex was negative, bilateral frontal, no response. People sluggishly reactive. Second case, temperature 100.2 BP, 120/70, oxygen saturation 98% with room air. GCS was 15/15 but decreased urinary output. She had his onset of fever on 29th of December while she was on duty. She took leave and went home. On 2nd, she consulted a local doctor in Bardhaman for high fever, headache, vomiting, and cough. On 3rd, late night, she had an episode of convulsion, frothing, involuntary urination, followed by loss of consciousness at home, as stated by her parents. On 4th, she was admitted to Bardhaman Medical College. There she was intubated, ventilated immediately after admission. Second case, he had a consulted in our OPD on 30th with a history of fever and headache for 3 days, along with sore throat, decreased urine output. In OPD basis, he was treated, but his temperature also was not decreased. For fever profile, he was tested and all the tests came negative. On 6th, she was transferred from Bardhaman Medical College to NH Parashat with the
ওরা
diagnosis
আজকে
of
এসে স্বাস্থ্যসাথীর কাজটাও সেরে
hypoxia.
ফিরে ফিরতে চাই, তো আমি বললাম যেটা হবে।
Excuse me, please mute. Okay. So on 6th, she was transferred from Bardhaman Medical College to NH Parashat with the diagnosis of hypoxic AES with aspiration pneumonia. On admission, she was intubated and under mechanical ventilation with very low GCS score. She had no history of comorbidities. And second case also, he presented to emergency on 4th with the brief complaint of fever with chills, sore throat, burning, micturition.
আগে ওরা কি বলছে দেখো।
With decreased urine output for 8 days, he was provisionally diagnosed with fever under evaluation, admitted in general ward and under the conservative treatment. First case on 9th, she had left lung collapse and bronchoscopy and tracheobronchial bronchial toileting was done. On 13th, she was diagnosed with VAP MDR. On 14th, tracheostomy was done. Gradually, she was weaned off from the ventilator support, which was started from 20th. On 27th, she was out of ventilator support and was on oxygen support with TPs. In second case, on 9th, he was shifted to HDU due to fever was not reduced, along with the respiratory distress, irrelevant speech, and drowsiness. On 10th, progression of respiratory distress was there and persistent drowsiness. He was shifted to ICU. On 10th, he had an episode of convulsion for 30 minutes. MRI brain was done with the revealed multifocal infarct. He was intubated and ventilated in the ICU with the GCS of 4/15. On 15th, he was extubated and was maintaining saturation in the room air. First case, on 31st onwards, she was maintaining oxygen saturation, though her GCS level was not too much improved, but she was maintaining the oxygen saturation. But on 3rd, she had again sudden onset of respiratory distress and she was connected to ventilator again. On 4th, she had fever, high fever, 101.6 degree Fahrenheit, increased CRP and CO2 retention. Body temperature was persistently high in spite of doing everything. All antibiotics were escalated depending on the culture reports. So in spite of doing everything, all critical care management and supportive management, she has succumbed to death on 12th February due to sepsis with septic shock. But in second case, he was recovered and discharged from the hospital on 31st. Now, the important thing is here. On the 10th, when this boy had the deterioration of the level of consciousness, then our consultant, they had a doubt. So they looked into 2 MRI feature and there they found the similar features are there, multifocal infarct in the MRI brain. Then they have gone through all the previous cases and they discussed with their colleagues in the AIMS Kollani at 10th night. So they decided to bring the team of infection control disease expert from the AIMS Kollani. So on 11 AIMS Kollani team, they came and they collected the samples, blood, urine, NPOP, so everything. So that report has given us the that Nipah virus RNA was positive for both the cases. But since it was not revealed because it was sent to NIV Pune and NIV Pune on 13th, they gave us the positive report of Nipah virus. So consequently, as per the government guidelines, RT-PCR was sent 5 days, 7 days interval. For second case, that 19th report came negative, and after after 5 days, it was said that RT-PCR came negative. So he was Nipah virus negative for consecutive in the 2 report. But in case of heart, the last report came negative on 23rd. These are the investigation profiles were done. Meningitis encephalitis profile, echo, X-rays, HRCT. Cultures for her, the continuous culture, it came growth of various bacteria. But in case of second case, there was no growth. In the EEG, there was difference for her. The EEG shows diffuse slowing in background activity, suggestive of encephalopathy. On 27, normal EEG in drowsy state, but her GCS level was not so much of improved. It was up to 4 to 5/15. But in case of second case, no significant abnormality noted. So the final diagnosis for first case, both the cases, Nipah virus positive with the AES, but in case of first, sepsis with septic shock, VAC, and autonomic dysfunction. But second case, acute symptomatic seizure, multifocal subcortical infarct, and LRTI. So the medical management were done in the ICU, more or less same for both the cases, antibiotic, antiviral, anticonvulsant, corticosteroid, and psychostimulant. Antiviral, initially acyclovir was given, but as per the government guidelines, ribavirin and remdesivir was administered. But in case of first case, that's antifungal and inotrops was there. So outcome of both the cases, that first case, septic shock, ARDS, persistent neurological deficit and multi-organ failure. She had succumbed to death on 12th. Duration of her hospital stay, 37 days. But second case, complication observed, LRTI, pleural effusion, ARDS, neurological deficit, He was recovered and discharged on 31st. Her duration of hospital stay is 28 days. But his neurological sequelae at discharge was gait impairment, left-sided weakness. Then he came for follow-up after 10 days, observed to have gait impairment and left-sided weakness. Next follow-up, he will come after 1 month. And we are doing the telephonic follow-up. He is doing well. He is trying to get out of his recovery. A little bit problem is there, balancing problem and gait problem is there, but he is on that period. So this is our aggressive nursing management, what we did during the period. Stringent infection control measures, aggressive hand hygiene, implemented negative pressure isolation, implemented of airborne and contact precaution, barrier nursing technique, strict PPE control, dedicated equipment for both of them, biomedical waste segregation and management, bundles care, risk-based single allocation, continuous neurological monitoring, that is GCS monitoring and seizure precaution. Respiratory care was taken with the web bundle, oral care, closed suction system, chest physiotherapy, fluid and nutritional balance, active and passive exercises, skin assessment and positioning changing. Family counseling also was done along with it, though they were in very anxiety and this state. So daily psychological counseling was done for them and restricted visitation protocol. What we did to prevent this outbreak? So we have done contact tracing in our hospital, total 69 along with the parents of both of them. Staff health monitoring, 11 was under institutional quarantine, followed by the home quarantine for 21 days as per the government guidelines. Isolation ward activated with the negative pressure. PPE audit compliance checking on daily basis. We have notified to public, that is District CMH, Shastha Bhavan, ICMR, NIV Pune and National Joint Outbreak Response Team. What we have done for preparedness, governance and policy readiness, screening and triage preparedness, PPE and infection prevention readiness, ICU, clinical preparedness. So challenges faced by us, high attrition rate due to fear of getting affected, manpower constraint due to home and institutional quarantine and attrition, psychological turmoil among the co-workers of the affected due to anticipated fear of being diseased and anticipated grieving. Heartfelt thanks to our all team members for their unwavering support and guidance while fighting against the Nipah virus infection. That is our critical care doctors, neurologists, pulmonologists, critical care nursing team, infection control team, emergency team, housekeeping and physiotherapy. Special thanks to our esteemed top management members for standing firmly behind our team. Key learning from these two cases that early isolation saves life. Exposure history is crucial. Strict infection control prevents the outbreak. Nursing vigilance improves the survival. Multidisciplinary coordination is essential. Awareness through training, protect yourself and protect others. At the conclusion, Nipah virus infection is highly fatal but preventable in hospital setting. Through strict infection control protocol, preparedness and rapid response, continuous surveillance, and through management. Nursing leadership here, it is very crucial in providing need-based quality patient care, infection prevention and control, along with interdisciplinary collaboration. These are the guidelines and reference we have taken. So thank you very much for your patience hearing. So now I would like to request Anita to give a highlights on government protocols.
Anita is thank you, Mukta, for giving us the case details so well, and that is from the leadership team coming. We know that how meticulously things have been done to an extent that was possible and that was required. So we want to hear now from Anita Roy, who is a staff nurse of critical care area of Sikabila Hospital, CMRI. Anita, over to you.
Yes, screen is visible.
Ma'am, is my screen visible?
Visible.
Yes.
You can put it in slide mode.
Okay. Good afternoon, ma'am. Good afternoon, everyone. So this is the Government of India's policy on Nipah virus management. Government policy has shifted from being reactive to proactive through the 2026 One Health framework. We are no longer just waiting for cases. We are screening every SARI and encephalitis patients in high-risk district for Nipah. The management of Nipah virus in India has evolved from emergency response to a standardized high-tech protocol. Even the virus's high fatality rate, which is 40% to 90%, the focus is on zero transmission. Now the risk categorization of contacts. High risk exposure description. Contacts with body fluids like blood, urine, vomitus, saliva, respiratory secretions, or confirmed or probable cases who died without a lab confirmation of Nipah and closed space in exposure for 12 hours. Next is low risk exposure description. Touching clothes, linens, or fomites of a positive of a detected patient or casual physical contact without body fluid exposure. Next one is high risk contact follow up and action. If the patient or the client is asymptomatic, then home quarantine for 21 days, active surveillance by health worker twice daily, standardized symptom checklist, start chemo prophylaxis, ribavirin and favipiravir. No test required at end of quarantine if remain asymptomatic. And in case of symptomatic, like fever or any symptom suggestive of Nipah, like severe fatigue, convulsion, altered mental status, etc., then immediate admission to designated isolation unit, collection of samples for testing, start IV remdesivir and oral ribavirin, send sample for RT-PCR. In case of RT-PCR is negative, 2 times in a 24 hours apart, discontinue. And in case of RT-PCR is positive, treat as a case. Chemoprophylaxis should be given to close contacts and high-risk caregivers without adequate protection. Pivavirin 600 mg orally BD for 14 days. Now the low-risk contact follow-up and actions. In case of asymptomatic, under observation for 21 days from last exposure, daily telephonic follow-up using standardized checklist, no test required at end of observation. And symptomatic, immediate admission to designated isolation unit, collection of samples for testing at earliest, and start IV remdesivir plus oral ribavirin. If contact becomes symptomatic during home quarantine, he or she should be admitted and treated as a symptomatic case. Healthcare workers with low risk exposure and remains asymptomatic may perform with adequate PPE including N95 mask. Now the triage and assessment of patient. First one is fever triage. All patients presenting with fever must report a dedicated fever triage point as the first step of contact. Epidemiological link. If an epidemiological link to a confirmed or suspected case is identified, the patient is immediately transferred to an isolation facility. Then PPE and safety protocols. Staff must wear appropriate PPE, apron, gloves, and adhere strict to infection control practices throughout the encounter. And the fourth one is ABCDE assessment. Follow the structured ABCDE approach for airway, breathing, circulation, disability, and exposure for all initial clinical assessments. Setting up an isolation facility. Admission criteria. In admission criteria, close contacts of confirmed cases presenting with fever or Nipah suggestive symptoms, healthcare workers symptomatic following contact with suspected or confirmed cases, high clinical suspicion of encephalitis, ARDS, or myocarditis during an active outbreak. Facility requirement. In facility requirement, restricted access, strictly demarcated area with separated donning and doffing and washing zones. In patient care, single rooms with attached toilets and dedicated equipments, and staffing only infection control trained healthcare workers. All staff entries logged in a dedicated register. Then supportive care and in supportive care, intensive supportive care, fluid electrolyte balance, and general respiratory care should be taken. Drug treatment options. No approved drugs or vaccines currently exist. All treatments are administered on a compassionate use basis or within clinical trial protocol. In ribavirin, the drug includes ribavirin, favipiravir, remdesivir, and monoclonal antibody. So there is also some protocol in these drugs, which I am now skipping for. Now the organ specific standard care, which is encephalitis, ARDS, and myocarditis. In encephalitis patient, there are also some protocols like elevate head of bed, like for 30-degree mannitol 1 gram per kg, or furosemide for raised ICP patients. In myocarditis, supportive care for heart failure, inotropes like dobutamine, dopamine we are using, and in ARDS, non-invasive ventilator as first line, severe or mechanical ventilator for tidal volume with high PEEP. In other therapeutics and psychological support, immunomodulators, institutional decision making, and psychological interventions are taken. For these are the criteria for discharge and follow-up: clinical stability, RT-PCR clearance, home isolation, and follow-up at day 28 day, follow-up at day 56 and 90 day. In specifically in RT-PCR clearance, 2 consecutive negative RT-PCR results within 24 to 48 hours apart required for from throat swab, urine, and blood, and long-term monitoring for late onset encephalitis and post-acute sequences. Thank you.
Thank you, Anita. It was a very nice presentation. We really, entire protocol was clear to us. Good. Thank you for presenting this. Now I'm coming to the next session, which is going to be our panel discussion. I would request all the participants to kindly put your questions in case you have any questions in the chat box, so that we can answer all the questions at the end. So let us go for this panel discussion, and here I would like to introduce Ms. Shampa Gupta, who is the Principal, College and School of Nursing, Narayana Hospital, Unit of Asia Art Foundation, and she is going to be today's moderator for panel discussion. Over to you, Shampa.
Thank you, Madhukuridi. Good afternoon, respected dignitaries, panelists, all participants, and the entire ANI family members. As all we know, that Nipah virus was first recognized during a large outbreak of encephalitis in 1998-99 among pig farmers in Malaysia. The outbreak was initially mistaken for Japanese encephalitis, but further investigations identified a new Paramax virus, later named as a Nipah virus, after Sangai Nipah village, where it was first isolated. Since then, periodic outbreaks have been reported in South and Southeast Asia, particularly in India and Bangladesh. Today's session focuses on Nipah virus, an emerging zoonotic infection that poses a serious public health threat due to its high mortality rate and outbreak potential. Now I take the privilege of introducing our distinguished panelists. We are happy to have Dr. Aniruddha Sarkar, Consultant Critical Care Medicine, PLS Hospital, Kolkata; Dr. Bikram Das, Consultant Infectious Diseases, Apollo Multidisciplinary Hospital, Kolkata; Dr. Riya Sarkar, Consultant Microbiology, Fortis Hospital, Anandapur, Kolkata; Ms. Sani Mary Pingram, ICN Supercare Hospital, Shillong; and Ms. Anandi Kundu, BSc Nursing student of College of Nursing, Tata Manin Hospital, Jharkhand. We are honored to have such a diverse and experienced panel. Now, without any further delay, my first question goes to Dr. Aniruddha Sarkar, Consultant Critical Care Medicine. So, when a patient presents with fever and neurological symptoms, Nipah may not be the first diagnosis that comes to mind. What early clinical clues sound immediately raise suspicion, and how critical is early isolation even before contamination? Over to you, sir.
Good morning, everyone. It was a wonderful previous 2 sessions, and the cases were beautifully elucidated. Initially, as the patients come to us in the ICU and all, we do not usually suspect Nipah, but few clinical clues that can guide us for the suspicion of Nipah is actually rapidity of the onset. Usually, patient worsen very rapidly within 24 to 48 hours of the first clinical symptoms. The patient tend to deteriorate. Usually, the patients present with a fever, myalgia, throat pain, nausea, vomiting, some flu-like symptoms. But majorly, two organ systems are involved. Primarily the respiratory and the neurological complications. They are of prime importance. Respiratory, because as we understood that the Nipah virus get attached to the epherin B2, B3 receptors of the respiratory epithelium. So this becomes the primary source of infection mainly, and causes respiratory infections like atypical pneumonia, which may lead to ARDS as well. Simultaneously, the attachment of the virus to the respiratory epithelium, it has a retrograde transmission of the virus, which enters into the CNS. And definitely, as been said by Mukta madam previously, because of the hematogenous spread as well, via the choroid plexus, it enters CNS. The CNS symptoms are usually encephalitis, not meningitis. The neurological symptoms that we usually tend to read, I haven't seen any Nipah virus patient actually, are usually drowsiness, fatigue, some sort of myoclonus, abnormal muscle movements of the neck, maybe of the diaphragm. Overall, a hypotonia, the muscles become flaccid, lax, the reflexes get depressed, and rapidity of the worsening of the symptoms of neurological status from conscious alert state to obviously unresponsive coma in a very short span of time. This accumulation of neurological and the respiratory symptoms, along with few of the thank you for not muting me. Uh, Along with these two symptoms, there are few lab symptoms that give us a clue. Typically, which gives us a clue in all prospective viral infection, is the presence of a leukopenia, some sort of thrombocytopenia, presence of altered liver enzymes, may be raised liver enzymes, that SGPT, SGOT may be raised, maybe raised CPK as well. All these features are generalized body infections with this leukopenic picture. This suggests a clue of viral infection. Primarily, uh, in this scenario, we will be very worried about Nipah. And it was very greatly picked up from that hospital, AYNA hospital, that they thought about it, about the Nipah. Moreover, the clinical clues that help in the Nipah is definitely MRI. MRI gives us some sort of cortical lesions, cortical hypodensities, which are actually not very specific for any disease. The combination of all these manifestations, and if at all there's a history of fruit ingestion for every Indian. So history of fruit ingestion is not a very telltale sign or a this thing that can guide us. But the rapidity of the disease, the all labs, blood and radiological features, they will help us to have a suspicion of Nipah. And definitely we need to send the samples as required.
Thank you, Dr. Aniruddha. So, when a patient is representing neuromuscular deficiency along with the respiratory and we have some marker, blood marker, we may suspicion that that may be a Nipah virus. From 2001 onwards, nearly annual outbreaks have been reported in Bangladesh, where transmission was primarily associated with consumption of raw dead pumps up contaminated by fruit bags. In India, outbreaks have occurred intermittently, notably in West Bengal and Kerala with high mortality. Now my question goes to Dr. Bikram Das, consultant in infectious diseases. What are the key epidemiological patterns observed in Nipah virus outbreaks across South Asia?
Thank you, madam. Thank you for the opportunity. Hope I am audible.
Yes, you are audible.
Okay, madam. I think we already discussed about epidemiology in detail in the previous slides, but I want to simplify a few key points regarding the epidemiology of Nipah virus. If we say about South Asia, then that includes the points like India, Bangladesh, Malaysia, Philippines, Singapore, like this. And there are some differences between the epidemiology of these two places. If we take the Bangladesh and India, that usually happens in the month of month between December to April or May, March, April. That is the winter or spring time, which is the harvesting season for date palm sap. And probably that is directly linked to the Nipah virus infection in Bangladesh and West Bengal. But if we take this infection from Kozhikode or the Kerala, then the timing is slightly different. So the season for this is around May to September, and there is no palm dates harvesting season that time, and it occurs mostly due to the half-eaten fruits or the contaminated fruits by the fruit bats, like that. If you take the same infection around Philippines or Malaysia, then that is not due to contact with directly with the bat, but it is contact with the intermediate host. For the Malaysia Singapore outbreaks in 1998 and 1999, it was contact with the contaminated pigs, whereas for Philippines, it was contact with the contaminated horse. So this happens by two clades of Nipah virus infection actually. So that's why the difference is there. In India, the Bangladesh, West Bengal, including the Kozhikode or Kerala outbreaks that are due to the Bangladesh clade, Nipah virus Bangladesh clade, whereas the Malaysia clade is causing the infections in the other. The slight difference in the syndromic presentation is there also. The ARDS and the encephalopathy, acute encephalopathy syndrome, the neuro and the pulmonary syndromes are more evident in our Bangladesh clade, that is in India and Bangladesh cases. Whereas for the Malaysian cases, the pulmonary involvement is lesser and more neurological involvement. So that's why the outcome is also different among these two. Among the Bangladesh clade, the mortality is quite higher. It is more than 70%. But for the Malaysian clades, the mortality is around 40%. So these are the key points we should focus. But most important is 75% of the infections occur in direct contact. That means human to human contact, and mostly the health workers are getting infected. That's where we should cut off. That's where we should do something to reduce the transmission, and the awareness is important for this. Thank you.
Thank you, Dr. Bikram. Now, Nipah virus outbreaks are characterized by low incidence but high severity, rather very high severity. So my question goes to Dr. Riya Sarkar. From a microbiological perspective, why is Nipah virus classified as a priority pathogen by the World Health Organization, and how it will be diagnosed? Dr.
Well,
Riya.
good afternoon, everyone. Well, I would like to modify your question a little bit. It is not a priority pathogen. It is a blueprint priority pathogen of WHO. I'll tell you the difference. Priority pathogen usually involves only bacteria, mostly, who are multi-drug resistant. So we categorize them 1, 2, 3, 4 who are most resistant and so on, so that antibiotics can be given that way. But blueprint priority pathogen are those, the curative list of those viruses and bacteria that have a potency to cause great public health risk. Because why? Because they are extremely transmissible. So they have the potential to cause epidemic and pandemic. And also, we do not have any corrective countermeasures regarding it. So all these characters make it a blueprint priority pathogen. Now, we all know that COVID-19, certain other diseases like SARS, MERS, Ebola, Zika, these are also blueprint priority pathogen, Nipah also being one of them. So there are multifactorial reasons for it. Like first, as Dr. Aniruddha correctly pointed out, the symptoms are very, very non-specific. There is no pinpoint symptom. There is no proper checklist that yes, this has happened, so it will be Nipah. The patient comes with fever, headache, fever, cough and cold. So very, very vague and non-specific symptoms. So it leads to delay and misdiagnosis often.
Yeah.
Number two, before you think that, okay, now it can be Nipah, after crossing all the differential diagnosis in your list, when you come to the Nipah, this patient has already transmitted the virus at various level already. right? So it
Yeah.
causes it has the capacity of causing a very rapid onset of the disease, as Dr. Aniruddha already said, and also it causes rapid worsening of the patient. So it kinds of outspaces the diagnosis, before we reach to the diagnosis, before the lab confirms, the patient is already bad. Then the fourth point is its huge case fatality rate, 40 to 75%. That is not a matter of joke. Huge mortality rate. So that makes it a blueprint priority pathogen. If we see our epidemiology, in May 2018, when we got the cases in Kerala, Kozhikode district, there were 18 confirmed cases and 16 of them passed away. So that was already 89% of mortality. So we did not stick between 40 to 75. So that is why it's very alarming. Lastly, we do not have adequate measures. We do not have vaccines. We do not have exact treatment, the exact antiviral that yes, this is to be given to treat Nipah virus. We just do the symptomatic approach and critical symptomatic care is given to the patient. But one of the most important, my favorite, I would say, point is there is a chance of zoonotic spillover. What do I mean by zoonotic spillover? Is animal, vertebrate animal who causes this, here it is the bat. It has a relationship with its nature. So it will always be the natural reservoir for Nipah virus. We cannot help that. We cannot break the relationship between the animal and nature, right? What we can do is prevent the chain or break the chain between the animal and the human being. So infection will keep on going. Bats will keep on being the reservoir for Nipah. The next approach is by us to prevent it. So all these parameters, I guess, make it like a blueprint priority pathogen for WHO. But also, I would like to say one more thing, that I've mentioned all the negative aspects that make it a blueprint pathogen. But one good point about being a blueprint pathogen is that this accelerates our system to be more efficient in do research and development in vaccines, research and development in diagnosis and therapeutic management.
Thank you, Dr. Diya. You are having also one question from the audience, which I will be asking later. But now I want to ask Shani, our sister Shani, infection control nurse, what infection prevention and control measures are critical when managing suspected Nipah cases in hospitals? Shani.
Yes, ma'am. Am I audible?
Yeah, you are.
Yes, ma'am. Okay, thank you, ma'am, for that question. As we have already discussed earlier, that Nipah virus is a highly fatal zoonotic virus. So, and because of its high mortality and potential for person-to-person spread, strict infection prevention is essential. So, preparedness must be when patient comes to the hospital. So if they are a known case, so preparedness must be immediate structure and discipline. So the first point will be immediate isolation readiness. That means we need to have a pre-designed isolation room with attached bathroom, and then we have to keep the dedicated equipments for the patient, that is like BP instruments, stethoscope and thermometer, and then preferably the room should be a negative pressure room. And then we also have to restrict the entry of the staff and the visitors. And the second point is that we have to have a strict infection prevention measures. That is by keeping ready the N95 respirator, gown, glove and face shield, and then designate donning and duffing areas. And because because most healthcare workers infection occurs during PPE removal. And then we also have to have a strict hand hygiene monitoring. And the third point is that we need to have a staff and workflow control. That means we have the duty hours of the staff should be limited so as to prevent fatigue of the staff. And we also need to have dedicated healthcare teams and no rotation of them, to other words, because this can lead to transmission of disease from one staff to another, that is cross contamination. And we also have to minimize number of staff entering the room. And then the fourth points is that we need to have a reporting and contact tracing. That is, immediately we have to notify this to the infection control committee, then inform the district surveillance authorities, and then also we have to start exposure risk assessment and contact tracing. And the fifth point is that we need to have an environmental and waste management by regular disinfection with biocidal agents like sodium hypochlorite, safe linen handling, and proper biomedical waste disposal. Thank you, ma'am.
Thank you, Sunny. So the surveillance and stringent infection prevention practice is very much required just for the prevention. Now my question goes to Anandi. As a student nurse, how will you explain Nipah virus transmission and the prevention strategies to the community people during outbreak? Anandi, over to you. Anandi, are you here?
Could you please unmute Anandi?
Anandi is unmuted. I don't know why.
Increase the volume. Increase your volume.
Anandi,
We can't hear you.
we can't hear you, Anandi. Okay, without delaying, we will answer both the question later on. Again, my question goes to Dr. Aniruddha. Like, based on the past outbreaks in India, what ICU preparedness are needed to combat this zoonotic threat? And one more question to you again, that if there is a survivor, can there is again a relapsing, or any they think they further acquire the Nipah virus infection? So that's the question of the audience also. Dr. Aniruddha.
Ma'am, whenever we are getting a patient suspicious of some disease and we are not able to zero in to the exact cause of the pathogen, we need to follow the stringent infection control practices. These are the actually backbone for not only doctors and nurses but also for the patients to get detected and cured. Infection control practices, primarily the droplet and the airborne practices, we need to use an N95 mask, particularly during aerosol generation procedures, bronchoscopy, nebulizations, and all. And definitely a broader perspective, an open eye, and a collaborative team approach will help us to detect these sort of not so common pathogens in ICU I2 patients. Yes, we do not have facility for every patient to be kept in an isolation. And yes, there are possibilities that the patient which are shifted in our ICUs might have some infections which can get transmitted to other patients as well. But yes, as I will reiterate that infection control practices, stringent practices are the backbone. Coming to the sequelae, yes, Nipah virus patients, they tend to have, as been elicited in our as the previous slides as well, they tend to have delayed neurological complications. And it is a rule for Nipah virus survivors to have neurological follow-up regularly. It is the perpetuation of the primary brain dysfunction because of the cortical infarct, the subcortical infarct that's been picked up by the MRI, which can prolong the encephalitis or the neurological sequelae. I am not very sure whether Nipah stays in our body and reactivates. I am not sure about that, but it is the primary damage that has been done by the virus, which tends to have prolonged neurological complications.
Thank you, Dr. Aniruddha. Dr. Bikram, we want to know certain more about the concept of One Health from you. And one more question to you: if any another Nipah outbreak occurring tomorrow, what was the one system level change that must be implemented immediately?
Okay, thank you, madam, for the question. Before understanding One Health concept, we should understand what is zoonosis actually. Zoonosis are some diseases that occur between human and animal. And when we talk about zoonotic diseases, we should understand that whatever disease, whatever infection we deal with in human, around 60% of them are actually zoonotic diseases. And whatever emerging diseases we are having these days, more than 75% are actually zoonotic diseases. And every year we get about five diseases new, emerging diseases. Of them, three will be zoonotic diseases. So this is how zoonotic disease is very, very important to know. And the concept of One Health came actually long back, but after 2003, the SARS infection, this came in a bigger way when we try to conceptualize the unity between human environment and the animal. There is a oneness. One cannot be thought excluding the other. The agent, host, and environment. This is very important in any infectious disease. And when we talk about host, in case of zoonotic diseases, there are different level of host. One will be a intermediate host, one will be dead-end host, one will be reservoir. The reservoir usually don't get infected, and this creates a chain which involves a lot of animal, lot of environmental factors. So unless we address each and everybody and we involve all the persons who are involved in the protection of human, animal, as well as the environment, it will not be possible to combat the disease. So the target of One Health concept is to involve everybody who are involved in the protection of animal health, human health, and the environmental health with collaboration, communication, and coordination, and to create optimum health for everybody. So this is how the One Health concept came, and now it is working well, and they are having also baseline surveillance data to get more information and how we can combat with the diseases. Coming to the next question, if another Nipah outbreak happens, obviously we don't want it happen again. But suppose if it happens, then we should be prepared, and probably two systemic interventions will be very important. One is the preemptive triage. That is a word we should understand. We get a ARDS or acute encephalopathy syndrome in an ICU, and we get a history of contact with suspected similar cases, Nipah or whatever with the AES. We should not take the patient directly to the general emergency. He should be taken in another room where we have the provision to contain the disease there for some time at least until we get a proper evaluation and further steps. So patient should not, this kind of patient should not be directly exposed to the general ear, number one. And number two is concept is the zero contact healthcare. That is very important, where the importance of the PPE comes, but the PPE is not only important. The other important thing is the professionalism with the PPE. The patient who the healthcare workers, only the professional and trained healthcare workers should be involved in the care of that patients. We should not allow the family members or untrained staff to handle this kind of patient, because that will only create a lot of transmission and it will complicate the problem. So we should train our staff, especially the emergency staff, to handle the PP, to handle this kind of patient. And if possible, we should keep one observer who are continuously observing the donning and doffing and the taking care of the patients. This is how probably we can contain the disease at the very outset, and then probably we have to go for the other measurements. I think they already discussed all this. So preemptive triage and no zero contact patient care.
Thank you, Dr. Bikram. Now my question goes to Dr. Ria. Now, how important is early laboratory confirmation in outbreak control, and what delays are commonly encountered? Along with that, audience wants to know that if the Nipah can be like a pandemic of COVID-19 or not. And as the Nipah is there is a 40 to 70% mortality rate because of the Nipah. Why vaccine development is so delayed? Dr. Ria.
Yeah, thank you. So first, diagnosis. Yes, early diagnosis is of prime importance, because as already we discussed, the symptoms are so much indistinguishable from common infections that already some delay has happened before you take the sample and put it to the lab. Now, early diagnosis will help us in three levels. One, in the patient level, there will be a documentary evidence. We can say that, yes, I need an isolation room. I can shift this patient. I want a critical care setup. I will give this patient supportive care, and patient management and patient surveillance improves. Number one. Second level where early diagnosis helps is towards the healthcare workers. Once I know that I am dealing with a positive Nipah patient, then I will be more alert in infection control practices, in wearing the PPE, and in preventing the transmission of this infection from one patient to another, from one patient to myself. Rather, cross infection can be handled. And on third level, which is very, very important, early diagnosis can actually lead to obstacle epidemic. How? It Once I know this patient is of Nipah, I can do the contact tracing. Just like we did in this time, we did 196 contact tracing. Fortunately, all of them were like, none of them had symptoms, so nothing positive came. So we can do the contact tracing. Once this contact tracing is done, you actually reach to the source. Once you reach the source, you can curb it and you can stop the outbreak. Just I'd like to mention in the slides, I think it got missed, so I'll tell you one interesting fact. The first case that happened in 1998 Malaysia, it is known as Malaysia-Singapore spillover. Why? Because Malaysia, the main source of infection were the pigs. Now these pigs were exported to Singapore. They did not know. So in Singapore, in 1999, suddenly they had an outbreak. When they did the contact tracing, they came to the point that these sick pigs from Malaysia are the source. So they combated this epidemic by just banning the import of pigs from Malaysia to Singapore. So this is the utility, or this is the wonderful approach of early diagnosis that can actually help to curb this outbreak. So this is your first part. Then yes, we have a delay. Definitely, you have to understand Nipah virus being a very high risk pathogen. It is a level 4 risk pathogen. So level 4 risk pathogen requires biosafety level 4. Now, biosafety level 4 is not a matter of joke. It is not found in every lab, urban, suburban regions you just leave. So we do not have it everywhere. So that restriction is there. You have to send to that particular lab which has a biosafety level 4 arrangement, because the proper handling is needed. Isolation of the virus and the containment procedures need to be perfect. That is number one. So molecular diagnostic setup is a restriction in most of the places we face every day. That's a real challenge. And also, I would say that since these labs are not available everywhere, so you have a time gap, you have a minimum, already a time has lapsed for the diagnosis, for the clinical diagnosis, and then there is a time gap for this lab confirmation. So that is why this delay. And what was your next question, madam?
The question was
vaccine. Yes.
Nipah. Can it be a pandemic like COVID-19?
Correct.
As the Nipah mortality is so high, 40 to 70%, but still there is no vaccine developed. So why
yes, so Nipah mortality is very high. That is why I told you that is just the positive part of being a part of blueprint priority pathogen. Government will definitely is ensuring, I'm sure, I am not very much aware of it, but definitely they are in the list who can ensure this advancement towards vaccines. We will surely be having soon, and as sir said, we hope that we do not get this outbreak any further, but we will definitely be having it soon.
Thank you, Dr. Ria. Anandi, are you ready?
Madam, I would like to add on a couple of things from my end, which we tend to face many a times. Like suppose we have a patient who has an ARDS and sort of neurological complaints. Say he has grown some sort of streptococcus pneumoniae. So we are not sure whether that patient has associated Nipah or not. Correct. So if we are planning to send a sample, then we face primarily two obstacles. First, the patient relatives will ask who will bear the cost if the test is negative. Second, we always have the fear in our mind that some of the legislative assemblies, the courts primarily, they will ask, you are sending unnecessary investigations to add on to the cost. These people will not understand the clinical scenario or the situations where we help people, healthcare workers work at. So from system change, I will suggest that eminent bodies like your body and all the bodies, if they cope up with some articles in the newspapers or the press media where ancillary testing should be done so as to change the public opinion, which will involve the judges as well for their opinion, because many times they tend to get biased because a doctor is guilty unless proved otherwise. So, so we need to change the public opinion. There are some few necessary tests which might come negative, but if they become positive, there will be some sort of public awareness thing. So some sort of suggestion from eminent bodies to government health institutions, health authorities might be thought about. It's just a
Yeah.
suggestion.
Thank you, Dr. Sharkar. Anandi, are you?
Anandi is ready. She put a message.
Okay.
She's ready.
Anandi, as you are a student nurse, and since last 1 year, 1 hour you are listening about the Nipah, now what is in your mind, how you can communicate to the community people about the Nipah virus transmission and prevention strategies, how they can prevent them during this outbreak, what they should do?
Thank you, ma'am, for the opportunity to speak. As a student nurse, I view health education is our primary intervention. We must explain how the virus spreads, as Nipah virus is a zoonotic disease, we all know, which means that it spreads from the animal to humans. People can become infected by eating fruits contaminated by the fruit bats, which is a natural reservoir of the Nipah virus. Drinking a raw date palm or through contact with the infected animals such as pigs. Another route of transmission is human to human transmission by direct contact with the infected person's respiratory secretions, blood or body fluids. While treating Nipah cases, nosocomial transmission also happens due to lapses in infection prevention and control. So to protect the community, certain preventive strategies must be adopted. Firstly, contact tracing, which is a process of identifying, assessing, and exposed to the diseases. It helps by identifying high-risk categories. What are these high-risk categories? They are they are those which are within the close range of an infected person who can enforce quarantine. Secondly, engagement of the grassroots level workers like ASHA workers, Anganwadi workers for the community surveillance and community surveillance activities. Thirdly, strengthening the health-related behavior, like providing mass health education through mass media, where we have to emphasize to never eat half-eaten or bird-baked fruits, or all the fruits and vegetables must be thoroughly washed before consumption. After advising against drinking raw date palm sap and which are most generally contaminated.
Thank you, Anundi. As already we are running 10 minutes, 12 minutes more, just very quickly, I want to know from the Sunny, like protocols are there in every hospital, but still transmission is there, error is there. Now you tell me, why does our system most often fail? Because just now Dr. Bikram told that zero contact. We have to be very professional about our PPE and all. So training, compliance, fatigue or fear, actually what is the barrier? So just can you highlight?
Okay, ma'am, thank you. Actually, protocols are usually well written, but the real problem is not on the documentation, it is the implementation under pressure. So, from my experience in infection prevention, failures most often occur in 4 areas. The first one is training gaps. Training is often theoretical. We give theoretical to the staff, but during real outbreaks, staff struggle with donning and doffing, especially during doffing of PPE. So, and skills deteriorate if not practiced. So that's why to prevent this, we have to conduct regular mock drills. We have to simulate base training and competency assessment and not lectures. So the second point is that compliance breakdown. Staff, when after doing heavy workload, then shortcuts happen like skipping hand hygiene, then adjusting mask improperly, rushing PPE removal. So to prevent this, we need to have an active supervision. We have to have an observer for PPE while by having a buddy system and real-time correction without blame. And the third point is fatigue. Long hours in PPE, as we already experienced during COVID, it will how we experience, so it causes us dehydration, exhaustion, and reduced alertness, and then fatigue increases error rate. So to prevent this, we need to have a shorter duty shift, routine planning, and adequate staffing. And we also need to have a hydration breaks. And the last point is fear and anxiety, as we already experience with COVID, that high fatality infections create panic, not to only the local people, even to us. So fear affects decision making and may lead to avoidance or improper technique. So that's why to prevent this, we have to have a transparent communication, daily briefing, then psychological support, and lastly, we have to have a clear post-exposure protocols. So from an IPC, the solution is not from IPC perspective. The solution is not on paperwork. It should be continuous, supportive. It should be continuous training. We need to have a supportive supervision, leadership ability, and staff protection. Thank you, ma'am.
Thank you, Sunny. Now, Anandi, can you explain within a minute that what role does a nurse play in early identification, isolation, and management of suspected Nipah case?
Yes, ma'am. Thank you, ma'am. So, in context of suspected Nipah virus cases, nurses play an important role. Regarding the early identification, nurses, as we all know, that nurses are the frontline workers in the hospitals. So, we perform daily systematic clinical assessment, including the detailed exposure history and the travel history, occupational history. We are going to assess the early clinical manifestations like fever, coughs, convulsions that must raise clinical suspicion on, and prompt recognition allows immediate action of infection prevention and treatment. Coming to the terms of isolation, according to WHO, suspected or confirmed Nipah virus cases should be placed in a single patient room. Nurses are responsible for implementing barrier nursing techniques and reverse barrier nursing techniques. Proper donning and doffing of PPE is essential. Nurses must ensure that restricted visitor access to prevent cross-infection. Thirdly, for the management part, since there is no definite antiviral therapy for Nipah virus, nursing care is largely supportive. This involves continuous monitoring of the vital signs, especially oxygen saturation, and neurological assessment like Glasgow Coma Scale, oxygen administration, active and passive exercises for the patient, fluid electrolyte balance, and timely escalation to the intensive care support in case of any deterioration. And additionally, nurses provides psychosocial support, health education, and counseling to remove all the fear and stigma during the outbreak. Thank you, ma'am.
Thank you, Anandi. So, from the insights shared today, it is evident that Nipah virus remains a significant zoonotic and public health threat. All the detection and rapid response systems are critical. Strict infection prevention protocols reduce nosocomial spread. Critical care preparedness significantly impacts survival outcomes. And the One Health framework is fundamental in preventing zoonotic spillover events. The convergence of environmental, animal, and human health highlights the necessity for collaborative strategies. So, addressing such threat requires strengthened surveillance system, laboratory capacity enhancement, critical care preparedness, rigorous infection control practice, and continuous professional education. On behalf of the organizing committee, I extend my sincere appreciation to our esteemed panelists for their scholarly contributions and to the audience for their engagement. Let us continue to strengthen interdisciplinary collaboration to mitigate emerging zoonotic threats and safeguard the global health. Thank you.
Thank you, Shampa, for excellently moderating the session. And I really, truly thank from Annie, all the panelists, those who have put in a lot of, good points for us to thought and to learn. There were a lot of learning from this session. But one question which had not been answered, I think most of the questions were answered. One question, if somebody can say, can survivors develop the relapse for encephalitis? That is the question that has been thought of from Nipah virus infection, which has come repeatedly as a question. If anybody,
Dr. Riya?
Yeah,
Okay,
anybody,
Dr.
Dr.
Anirudh
Riya,
will
Dr.
answer.
Vikram, Dr. Anirudh.
Ma'am, I do not think it's the relapse, but it is the persistence of the neurological
May I
symptoms
pitch in?
post Nipah infection.
Okay.
So, Captain Madhukari, Dr. Riya would like to add one point.
Yeah, sure, please.
Now, just from a microbiologist point of view, like if I have to tell that at least one single, approach that should be there, not only for Nipah, for any outbreak or any transmission, one thing that everyone should follow in hospital is infection control practices, hand hygiene. So I think if 100% hand hygiene we follow everywhere,
yes,
obviously I'm not talking about preventing Nipah, but at least we can prevent the transmission throughout the year. We just don't have to wait for that particular outbreak to occur, that particular time of the year that yes, now there is infection in the air and I need to do the hand hygiene and follow the practices. That should be a practice. So if that everyone can follow, it might help.
The most important and the perfect step that we should take, all of us, all caregivers. Thank you once again, Dr. Riya. So with that, we come to the end of the session, and I hand over the mic to Dolly Vishwas, who is the CNO of Fortis Hospital, Kolkata, and also now the National Secretary of ANI.
Thank you.
Congratulations, Dolly, and you have many hats on your on your head.
Thank you
So
so
with that, you are also the AYNA zonal president. So in the zone, so you have a lot of things to do. With that, I just invite you for closing remarks.
Sure. Thank you very much, Captain Madhukaridi. First of all, when we were thinking about that, what topic can be selected for this Eastern Zone, any AYNA Empower or panel discussion. So me and Madhukaridi first we discussed and thought that let us go ahead with the Nipah. It is not to create a panic amongst the fraternity or those who listen today, but just for an awareness from end to end, like having the virus in and up to the exit point, and later on also if whether there is any chance of developing complication. That was only the motto that we kept in mind, nothing else. So my deepest gratitude and thank you to Captain Madhukari, who is the zonal president of Association of Nurse Executive of India and holding a regional director position in Apollo Multispeciality Hospital, Kolkata. She is having lots of responsibility. And in spite of that, Didi, you are always giving time and conducting such a great knowledge sharing program. And then we both of us connected to Shampa and said that Shampa, how can we frame the entire, the Empower Hours of Annie? So she said, Didi, let us start with the case presentation, which Mukta is ready to do. And she has guided Mukta throughout the presentation, and wonderful job that Mukta has done. Every one of us are enjoyed sharing, and you have seen the, the reactions on the screen when she has completed her presentation, comparing both the cases. Fantastic work, Mukta, you have done. Then comes the Anita, who has actually read the entire guideline, and you have done a great job of understanding and giving us the detail of the guideline. Then the moderator, Miss Shampa, who is always vibrant, nursing leader. She is the principal of NH, which is a unit of Rabindranath Tagore International Institute. And she is not only taking care of her college for the BSc and GNM and MSc students, but she is having a lot of role. She is playing in the clinical field with the nursing superintendent of NH Hospital, and she has moderated the session. Thank you very much, Shampa.
You're most welcome.
all the brilliant panel member, right from Dr. Aniruddha, Dr. Bikram, Dr. Ria. Just one call and you people have accepted our invitation for participating for the panel, and lots of love to all of you, lot of thank you to all of you. And my dearest Anita and Anandi, both of them also have done a brilliant job today by discussing entire viewpoint. All the online delegates, those who have joined for this particular any Empower Our AYNA event from the Eastern Zone, not only that, from all over India, almost I have circulated to all the group. Manushi, for a lot of work she is doing for Association of Nurse Executive of India, Arpita, and entire online delegates, those who are here with us. Thank you very much for your brilliant time spent and learned. It was really a session where we were requiring it because we got the understanding Nipah will be there, what all to be done. But today we got absolute clarity in our mind that how we have to progress, what can happen, what is there. So with our all the doctors, the nursing fraternity, Captain Madhukari, Shampa, you have done very nice job. Thank you from the core of my heart. Thank you so much. Already we are about the time of 20 minutes. So I am just winding off completely. Thank you very much and namaskar to all
I
of you.
also want to I take this opportunity to thank the president of ANI, who is Captain Ajita Nair, and Thankam Madam, without whose support it was not possible. She is not only the former president, but also each beat of ANI today where it stands. It is her brainchild and it is like her child. So we thank from core of our heart, we thank both of them to have this platform for us to learn. Thank you so much. And thanks to all of you. Yeah.
Thank you.
Ma'am,
I just would like to ask,
Manashi
we
wanted
can
to say something.
Yes, Manashi.
Yes.
Yes.
Ma'am, actually, since chapter gathered here, on behalf of chapters, I would like to congratulate both of you for for being selected of President of INS India to Captain Madhukari, and for being selected as Secretary of ANI, Dolly Madam. Thank you. Many congratulations on behalf of chapter, and thank you for being the torchbearer for us.
I just would like to tell that everyone, could you please enable your camera so that we can take a group photo for our record?
Group photo need to go.
Yeah.
Please, group photo.
I'm after the cast.
We'll both stand together.
I can see Manushi and all, but the entire group. Just a minute. Just a minute. Can we have the gallery view? Somebody can do just a minute. Let me just do a gallery view. Yeah. I got it. Yeah. Yeah, please enable everyone's camera so that we can take the photo. Thank you. Thank you. Great. Have a nice day. Thank you. Thank you so much. We can leave now.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am.